Welcome to The Explainer. Today, we're diving into a technology that has completely changed how anesthetists and surgeons see the heart in the operating room, 3D Transoesophageal Echocardiography. And if you're studying anesthesia, you know this isn't just some minor upgrade. It's a total paradigm shift.
But before we jump into the solution, you've got to appreciate the problem they were up against. For years, this was the central challenge. The heart is this incredibly complex, beating 3D structure, but the only view clinicians had was a series of flat 2D ultrasound slices. How do you possibly make life or death surgical decisions based on that? The old way, well, it was all about mental gymnastics. You had to take all these flat pictures and then try to stitch them together in your head to build a 3D image. But the new way, with 3D TOE, just gets rid of all that guesswork. It gives you a direct, intuitive model of the patient's actual heart, right there, in real time.
So here's what we're going to cover. We'll start with that fundamental problem of 2D imaging, then see how the first big breakthrough came with TOE. Explore the 3D revolution, look at its real-world clinical impact, and finally, take a little peek at what the future holds.
Okay, let's kick things off with that original hurdle, the one clinicians had to deal with for decades.
You know, this analogy is absolutely spot on. Standard 2D ultrasound gives you these predefined slices, forcing you to mentally build the full picture. And that's not just tough to do. You could totally miss complex problems, especially if you're trying to figure out exactly where a valve is leaking from or the true size of a hole in the heart. So the first big leap forward wasn't even about adding another dimension. No, it was all about getting a better view. This led to something called Transoesophageal Echocardiography, or TOE. So what is TOE? Well, instead of trying to look from the outside, through bone and lung tissue, you place a tiny probe down the esophagus, which sits right behind the heart. This gives you this incredible, clear, high-resolution view of all the cardiac structures that you just can't get from outside the chest.
And look, don't think for a second this is just some nice-to-have gadget. The information you get from TOE is so critical that study after study has shown it directly changes the surgical plan in about 15% of cases. Think about that. In roughly 1 out of every 7 cardiac surgeries, the surgeon changes course because of what TOE finds right there on the table.
Okay, so TOE gave us a much clearer picture, but the real game changer, the thing that truly blew the doors open, was when we went from that clear, flat picture to a full, moving, 3D model. Okay, this slide right here says it all. On the left, you've got your standard 2D slice. It's informative, sure, but it's abstract. On the right, that's the 3D TO view. It's what we call an in-face, or surgeon's eye view. It is literally what the surgeon would see if they could just look directly at the valve. No more guessing. It's a massive leap. And here's the crucial part. This 3D advantage isn't just for one thing. It helps across the board. For the mitral valve, you get that perfect surgeon's eye view to see exactly why it's leaking. For the aortic root, you can get precise measurements that are super tricky in 2D. For the ventricles, you get way more accurate calculations of volume and function. And for things like growths or clots on the heart, you can intuitively see their size, where they are, and how they're attached. Okay, so that's the theory. Let's talk about how this actually plays out in the OR, in real clinical situations that you're going to see. Let's take aortic stenosis. Figuring out how bad it is means you have to measure the valve area accurately. Now, with 2D, it's super easy to slice the valve at a weird angle and get the measurement wrong, which is a big deal. But with 3D TEO, you just trace the actual opening. It's simple, it's direct, and it's way, way more accurate. And check this out. This is how we can see how well the ventricle is actually pumping. The software takes all that 3D data and automatically builds this dynamic model of the heart wall. From that, you get these super accurate, reproducible numbers for volume and ejection fraction, which are key indicators of heart health that guide everything you do during surgery. So beyond just taking pictures and measurements, 3D to High has become this indispensable guide for actually doing things in real time. For really complex procedures like putting in a new aortic valve through a catheter, a TAVI, or placing a MitraClip to fix a leaky valve, it provides the visual guidance you need to get these devices in exactly the right spot. It's also crucial for complex congenital repairs and even guiding needles safely between heart chambers. But the story doesn't end on the screen. The data we get from this is so good, it's now leaping out of the computer and into the real world in ways that honestly sound like science fiction. That's right.
We can now take these incredibly detailed 3D datasets and use them to 3D print a tangible, physical model of a specific patient's heart. I mean, think about that. A surgeon can hold a perfect replica of the very heart they're about to operate on in their hands before they ever make a single incision. This just opens up mind-blowing possibilities, right? Could you actually do a dry run of a super complex congenital heart surgery on a custom-printed model? Yeah, that's where we're headed. It's a technology that isn't just changing how we see during an operation. It's changing how we prepare, plan, and train for the most difficult cases imaginable. So there you have it. That's 3D TO, a technology that took us from piecing together flat slices to seeing a live dynamic 3D model, and now to actually holding a physical copy of the heart in our hands. It has truly changed how we see, understand, and repair the human heart. This explainer was based on the 2024 articles Perioperative 3D Transoesophageal Echocardiography Parts 1 and 2 from BJA Education.